All right, or do you want to start? What do you want to go over? Heart sounds, all right. Heart sounds or heart murmurs? Because heart sounds is 1, 2, 3, 4. Done. Yeah, so S1, S2. So let me get a drawing going here. Let's share drawing. All right, so yeah, so heart sounds, you have S1, S2, right? S1, S2. Okay, so there is a pattern to this, and it keeps going, right? S2 will be after S1, right? Those are normal heart sounds, right? S1 is closure of what?
The valves?
Of valves, right? The AV valves specifically, right? So if you're drawing a little heart here at the bottom, I guess, let's put over here, it's your valve closure on the left and the right side, right? And the valves next to it are opened for systole, right? Do you know what I'm doing here? That's a heart, sort of, right? So yeah, so those are your AV valves closed, right? Let me use a different color too. All right, so these AV valves, the mitral and the tricuspid closed, right? And that closure created S1, right? So that's a sound icon, right? So they closed, all right? So you have S1, and that means what is happening here? Where's my highlighter at? There it is. All right, what is this action right here? This is going to the pulmonary arteries, this is going to the arteries, aorta. That's systole, right? So S1 is the onset of systole, okay? So if it happens between S1, S2, or if you have a murmur, right? So murmurs are put in red, I guess, right? You have a murmur with an opening snap or something, that is a systolic murmur, right? S2 is what? That's closure of the semilunar valves, right? Which is the opposite of the AV valves. So you have the closure of the aortic valve and the what other valve? And the opening of the tricuspid and bicuspid, or tricuspid and mitral valves, right? And we are now filling up the ventricles, right? When we say diastole, we're usually always referring to the ventricles. We can be specific and say atrial diastole, but you're just mostly speaking about the ventricles, right? 99% of the time. So that is diastole there. So let's be consistent here. So we got diastole, right? All right, you're filling up with blood. I don't have a cute mnemonic for this, which is diastole, right? So between S2, S1 is diastole, between S1, S2 is systole, right? So that's your normal heart sounds, right? So let's save this guy. It's a beautiful picture. Let's do a new one. New, where's new at? I know it. Clear, okay. Okay, so then you have S1, S2, S3, S4, right? So you have S1, right? You have S2, oops, S2, and you have S1, S2, right? So S3, S4 are due to dilation or hypertrophy most commonly, right? And they are abnormal. Sometimes there's normal, like in pregnancy and such, but they're abnormal. So let's draw that in red then. So S3 happens when? It's right after here. So that's S3, right? S4 happens right before systole, all right? So S4 is kind of easier to explain because what's happening S2, you're filling your blood, you're doing diastole here. Let's draw the purple, right? Or blue, I guess. Right, so you're doing diastole here, right? And remember S1 turns into a systole. Okay, so you have systole there, you got diastole there, and S4 is due to what? Hypertrophy or dilated ventricles? Yeah, it's hypertrophy, right? So if we try a little hypertrophy, beefy ventricle here, right? Oh, yeah. Super swole, right? We got a mitral valve that's open. We're right at the end of diastole, right? And we're putting blood in, and then what happens? We have a atrial kick, right? And atrial kick is like, it's already closed, and still got to push everything into the closet to close it, right? So it's a little atrial kick creates that little S4, right? The atrial kick against a full ventricle already, right? Whereas S2, let's draw different colors too, darker red, I guess, or sorry, S3, that says an S4 over here, right? S3 is where you have a super dilated ventricle, right? It's very thin walled, and you have the mitral valve still open. We're still filling blood in, right? But basically it's just opened up, right? And now it's opened up into like a huge crevasse or a huge canyon. And as you can hear Wilhelm scream, "Ah," and it sloshes, right? And it sloshes against it, and that sloshing sound is the S3. So it's bump bump, or you don't hear a sh, you hear a bump bump bump, right? You hear another bump after that S2, right? Because diastole it's opened up, and now it's going to hit against it like a spittoon, right? Whereas a normal size, it's just going to kind of just slide right in like a normal slide. Whereas S4, it's already full and it has to kick it, and it creates a little extra bump, right? And these are not murmurs; these are heart sounds, right? And what does S stand for? Sound. They weren't that creative in the 1800s, all right? So sound 1, sound 2, right? And then they heard sound 3. It's like, oh, what is this, right? And then they said, what would we call it? The other sound 4, all right? They call them the same guy. Yes. Yeah, so it opens up right after S2 is the start of diastole. Your mitral valve's open, or your tricuspid also, and just kind of sloshes in there, right? So those are your heart sounds, right? So the important thing for the test is to know the murmurs and where they occur in this thing, in this layout.
Where in this?
Okay. So you have systolic murmurs and diastolic murmurs, right? So systolic murmurs occur between where? Between S1, S2, right? So new slide here. All right, so you have S1, S2. You got S1 over here, whoops. All right, you got S2 over there, right? So you have diastolic murmurs, right, which are what? So you have diastolic murmurs, which occur here, right? These are your diastolic murmurs. And these are just your arms and your parts. So aortic regurg and mitral stenosis. Okay. And where are your systolic murmurs out? What color is systolic? Blue, maybe? Right? So systolic murmurs occur here, right? Systolic murmurs. That's ugly. Anyways, you got systolic murmurs. All right, they occur between S1 and S2, right? Diastolic are between S2 and S1, or diastolic are before S1, and systolic are after S1, right? So you can word that however you want, but if it occurs in that space, it's systolic or diastolic, right? And your systolic murmurs are which ones? And not MS, but MR, right? / MVP. Okay. So if it's not arms, it's parts, or not parts. If it's not arms parts are your diastolic murmurs, right? And if it's not arms, then it's the other one. So AR, opposite of AR is aortic stenosis. Opposite of mitral stenosis is mitral regurg, right? And it should make sense. I mean, when it's happening. So if you have mitral stenosis, that's a valve that doesn't open all the way. And when is the mitral valve supposed to open? During diastole, right? When it's trying to empty. So you're going to hear a lot of whooshing during that time, right? Make sense? All right, so I'll save that image as well. All right, so that's your murmurs and heart sounds. Where's the? Let's go share here. Screen.
Can you go over what exactly is happening with mitral regurgitation?
Mitral regurg? Which part of it?
I guess on the systole. Like, is it just because it's damaged, or?
So mitral regurg is you have a mitral valve that is incompetent, right? It has a little chordae tendineae on it, so it could be attached to papillary muscle, right? Here's your left ventricle, your aorta. Well, that's your mitral valve right there, but a little bit far. But anyways, during systole, it should be closed, right? So it's incompetent. So it's just put it incompetent, right? So it's going to have, let's see here. All right, during systole, you are pumping blood out of the aortic valve, right? And you are also pumping blood this way because it's incompetent, right? So you're going to hear it during diastole or systole. During systole, it's a systolic murmur, right? And because of that, you're going to cause this left atria to get bigger and bigger and bigger and compress the structures right behind it, which is what? The esophagus. So you get a hoarse voice, right? right? You get a hoarse voice and you get dysphagia, right? Trouble swallowing, etc. Right? So that's kind of usually a complaint, and then eventually that's gonna back up into the lungs, right? And you're gonna get some left-sided heart failure symptoms, right? Right, you get some dyspnea, and that could put extra pressure on the lungs, and eventually could lead even to right heart failure, right, if it's untreated. But usually these things get noticed in America, and we can recognize these things earlier, right? And when we assess them, all pediatric patients get assessed usually, and then as you get older, we can, people can, if it's like a level 4, level 5, 6, you can actually hear it across the room or hear it in the same room. It's like, dang, what's going on over there? All right. All right, what else? Save that beautiful picture here.
Yeah, good.
All right, so yes, I put that over here, and we talk about the valves. So there's a study guide kind of put together. It's just I'll add to it today as I finalize the test and make sure we have all the little things in there you got to know about. But yeah, this is kind of just a summary of all the content in the slides. Again, the slides are to explain these symptoms, and then you can, once you just see it on its own, that should then trigger like a, again, a ratatouille moment. It's like, oh yeah, systole, right? And it's S1, S2, and you can again go back and apply it. Okay, so I still got to put like CAD and stuff. There's a few things that we didn't get into. All right, but like valves, like when you talk about valves, I'm going to usually give you like 2 out of 3 of these things. Hopefully, usually I'm aiming to get you 3 of these things where I tell you it happened between S1, S2, or it happened before S1, S2, before S1, or after S2, or happened between S2, S1. So it could be phrased any one of those ways, right? So that tells you it's systolic or diastolic. And now you have just a few options, right? So it's like impossible. So when is it impossible to have aortic stenosis? Between if it occurs between S2, S1, or between S1, S2? Aortic stenosis is a systolic murmur, right? So it's impossible for it to occur between S2, S1. So that's one of your options. Cool job. All right. So anyways, you're going to have a systolic murmur is aortic stenosis, right? And then the other piece is, where did you hear it best, right? When you hear aortic stenosis, you're not going to hear it. You're going to hear it best over the aortic area, not over the mitral area, not over the apical area. Where's the apical area? The mitral area, right? And where you're going to hear it, you're not going to hear it best over the pulmonic area. You're going to hear pulmonic valve issues over the pulmonic area. You're going to hear tricuspid issues over where? The tricuspid area, right? So you have to know where those zones are, and that's what you do every semester is your assessment, right? I assess ape to man or whatever other non-controversial mnemonic you have, all right? So what else you have? So those are the 2 things you're looking at. So that's really going to narrow it down, right? You have, where do I hear it best? I hear it best over the aortic area. That means it's only 2 options. It's going to be either aortic regurg or aortic stenosis. I tell you it's between S1, S2 or S2, S1, then that's really almost all you need, right? And then we can add some extra flavor in there, extra spice, right? You can then do maneuvers, right? Because every murmur gets louder, except for these guys right here, right? And even I was going to take off MR because I think that was a mistake on the slides. But MVP gets quieter with more preload, right? Whereas every other murmur gets louder. Okay. And then more afterload equals more murmur also for every murmur except for aortic stenosis. All right, so those are the exceptions. All right, so that's the extra flavor. Yes. For more afterload, I'll have to look at it, but it's usually going to be aortic stenosis. That's the most common one. Okay.
Yeah, more afterload.
Usually it's louder with more afterload, which is you're squeezing and like deep squats. All right. So what else on valves? So valves you can't just ignore. They are complicated, and that's why we developed the echo in the 80s. So nobody has to listen to valves anymore, but you still have to do it. All right, still have to, you can hear things and then ask for an echo afterwards. Like I hear extra heart sounds, which are not murmurs, or I hear something whooshing between S2, S1 or S1, S2. All right. So when you're auscultating, you can hear like bump, bump, shh, bump, bump, shh, bump, bump, shh. All right, that is a what? Diastolic or systolic? I'm not going to release my Spotify track on the test. Don't worry. All right, so that'd be a diastolic murmur, right? So then you can hear the word I hear that best now. So then you can kind of auscultate where do I hear that the best, right? If I hear best over the mitral area, what is it? There was no opening click. I can't do that. Bump. I can't do that. Anyways, you're gonna have, yeah. So you have it's gonna hear best of the mitral area and it's diastolic. That's gonna be mitral stenosis, right? What else? Are you good on valves? So like symptoms are usually CHF symptoms, right? Because all the chamber has extra volume to deal with. It's either able not to get out, like air stenosis or mitral stenosis, or it's getting all kinds of backflow because of regurgitation or regurgitation, aortic regurg or mitral regurg.
With maneuvers, thinking slide was talking about like hand grips. Why exactly?
So when you hand grip, you're increasing the pressure in the chest or in the heart is working against.
Gotcha.
Yeah.
So
it's difficult to do foot grips. I can't do foot grips. What's up?
that would be the same thing as like kneeling or.
So yeah, so the question was afterload, why does it increase with hand grips? Because you're contracting your vessels, right? You're going to be able to appreciate a louder murmur if that murmur responds to increased afterload, which is all of them except for aortic stenosis.
Gotcha.
Right. And if you do a deep squat, you now are pinching off the femoral arteries, right? If you raise the legs, that puts more volume from the legs into the chest if they're sitting, right? If they stand up, all the blood goes to the legs, and that's going to make the heart smaller, and you can be able to appreciate murmurs better, or murmurs not as good, except for which one?
So for
MVP, right? All right, so those are the maneuvers. That's just extra flavor, but you should be able to get the answer from the first two pieces, right? All right, so yeah, so again, everything is kind of categorized. These are all just the symptoms, right? But the causes, what are the causes of valve issues? All right, ASCVD is a good answer if you have to guess, right? So you have causes, right? You got age is attributing to it, right? You get age, you get calcified, right? You get old and so that's going to calcify, most kind of like the aortic valve. It's the one that gets the most pressure, most calcium, but that calcification can do it. And then structural issues with age also, but also with just CHF due to MI as a result of ASCVD, right? And other causes CHF. And then a little extra moving on, or a good segue into the carditis is not the Kardashians, but the Carditis is the endocarditis, right? So endocarditis can cause IV drug abuse, can be caused by IV drug abuse, collapses, and a few other things, right? Rheumatic fever and such. So those are your causes, right? You got causes, symptoms, you got treatment. How do you treat these valve situations? Underlying cause is the best answer, right? So if they have CHF, fix the CHF. They have age, cut their head off and put them in a cryogenic freezer. I don't know. So you're gonna do, but anyways, endocarditis, we can fix that, right? We give what? Give antibiotics for how long? 4 to 6 weeks usually. Okay. All right. So we talked about symptoms, causes, and then we have treatments, right? CHF treatment, endocarditis, antibiotics, and we have surgeries and procedures we can do. We can do endovascular procedures before we crack open the chest and open up the heart, right? We can do endovascular where we go through a vessel, right? Up into the heart, usually the femoral artery. They put a catheter in there, go all the way up, and they can just replace the valve. That's a new thing in the last 15 years. All right, replace the valve, or they just go in there and do a little vaginal rejuvenation, cut some lips off. So they can do that too. Okay, or they can sew them together. Okay, a commiserotomy or what else? Okay, so yeah, and then there's the prolapsed, right? You got prolapsed. Right.
That clipping.
Sewing together is different than clipping, but there's different things they can do. The balloon, they can open up a little bit with like mitral stenosis, right? Yeah. What else? So then so for some of the murmurs, they have like unique things that people put their name attached to, right? Someone was really upset about the sound 1, sound 2 things. Like, I need my name on that. So let's put that Quincke, right? I got Quincke's pulses, right? That's where all the blood goes to your capillaries and it just leaves because it was there. It's like, I'm here, and you get called home, right? All back, it squeezed all the blood back into the left ventricle. Okay, because that aortic valve is supposed to be shut, right? When you squeeze, the aorta squeezes the blood forward and during diastole, but all the blood squeezed a little bit forward, but then all left back or all went back to where it came from, into LV. Okay. Yeah, water hemorrhage is the same thing. If you were to, that's what you would visualize. And if you were to feel it, you'd feel the strong pulse to begin with, because your blood flow is compromised, and the SNS is like, what the hell, where's my blood at? And it's going to increase the demand, right? And it's going to make it really go far out, and then it's going to all go back into the LV because the valve is incompetent, right? All right, we talked about dysphagia, and then you have structural damage, that's AFib, right? Get big left atrium. Now it's, the SA node fires off and goes the AV node, and it's like, where's the AV node at? All right, where's the left atrium at, right? And then then it finally comes around, and then they fight, and you got AFib or aflutter. All right, good. So carditis, do you want to go there, or what do you want to go next? So carditis, you got 3 flavors. What are they? Endo, myo, and peri, right? The one that has the least kind of information is the myocarditis. That's usually just sustained damage to the heart, usually due to infection of some sort, right? You don't just like get it, right? It's usually something happened that caused the myocarditis, right? They usually have like persistent tachycardia, persistent chest pain. That's not really, and of course they can do a workup, and they're going to be able to see that, oh, it's really, that's really a beefy ventricle, or it's inflamed. They can see that on echo, right? Every cardiac condition gets an echo, right? And they get an X-ray also, because you can kind of see the heart a little bit too, right? And also we can rule out dissecting aneurysm. But when you talk about lungs, right, next time we're gonna be talking about you're doing ABGs and X-rays. That's their bread and butter. But for cardiac, it's echoes and EKGs. Okay, so infective endocarditis, you got echoes for everybody, but they got another extra special 8K echo, right? Which is called what? A TEE, a transesophageal echo, versus a transthoracic echo, which doesn't hurt, doesn't require consent, right? So that's the transesophageal echo, requires consent, and it's a whole thing, right? You have to go and require sedation, and that definitely you can see what the valve issue is. And the reason why you would do that is because they saw something sus on the echo. You pull the reports as sus. Oh, okay, I gotta get TEE now. Okay, and you're gonna have a murmur because it's going to accumulate on the valves, right? Most commonly, it's something infectious, right? And then it accumulates on the valve, and the valve is gonna keep, it goes every beat, it's moving, and then it's going to just dislodge that, and it's going to go somewhere, right? You can go to the skin, and you get those the JOS, right? You get the Janeway, Osler, and splinter hemorrhages, right? And that's like the least worrisome finding, because the other thing it can do is just go to the brain and cause a massive stroke. All right, it can go to the lungs and cause PE.
So is it just causing like infectious areas?
No, it's because you have it's a whole group of bacteria and clots and everything that's in there, in that valve that's compromised. All right. So you have mitral stenosis or mitral regurg, or aortic stenosis, aortic regurg, or tricuspid regurg, tricuspid stenosis. They could have a valve issue, and then it can then dislodge and travel. Right. And all your carditis is also the same. One thing that's similar is they all have a infectious presentation. So they have a fever, a white count, and SNS firing off. Right. Because your SNS fires off when you have an immune reaction, when you have a fever. Right. So that's what's common. So that's going to clue you in that I have a carditis going on. And your carditis can lead to CHF, right? If you have untreated infective endocarditis, that's a valve issue, and the valve issues are a cause of CHF, right? You get arrhythmias if it causes chamber enlargements and such. All right, so mentioned continue with endocarditis, you get the septic emboli. You need antibiotics for this, right? And interventions for high risk patients that they need they've had endocarditis before, they're pregnant. These are things that are high risk, where they have to get invasive dental work that you get antibiotics. Used to be everybody got antibiotics, but no. Okay. And we talk about myocarditis, got persistent chest pain. Okay. Spontaneous resolution or death is how myocarditis plays out. And then pericarditis, right? That has a complication that we could talk more about, right? Which is cardiac tamponade, where you have too much fluid around the heart, right? Right. Pericarditis is just inflamed, and then sometimes it's inflamed and can increase the fluid there as well, as you have an effusion that can develop. And then you get you have the infection presentation. And also, what else do you hear on symptoms for pericarditis? Muffled is going to be cardiac tamponade, but for pericarditis, you're going to have what? Pericardial rub, right? You get a rub sound. It sounds like leather, right? And again, infection is the most common, right? cancers, autoimmune conditions can make you develop pericarditis. All right, and your symptoms, you got the rub and you got chest pain. When we talk about chest pain, how to differentiate chest pain, right? Versus cardiac chest pain versus aortic aneurysm chest pain, right? Versus a PE chest pain, which is something we learned about, right? And then we have pericarditis chest pain, which is what? It's positional chest pain, right? Which is not cardiac chest pain, right? Or yes, it's the heart, but it's not anginal chest pain or myocardial ischemia chest pain, right? And it gets better with what? It gets better with leaning forward. It gets worse with leaning down. It gets, you have to think about either option, right? What else? All right, it gets better with high Fowlers or worse with high Fowlers? It's gonna get better with high Fowlers, right? High Fowlers is sitting up, right? So with Trendelenburg, does it get worse or better? It gets worse, right? What other positions with lithotomy position? Does it get worse or better? Lithotomy. You guys can take OB with moms and you're pushing the legs back, right? All right, anyways. Yeah, when's your last pap smear? Dude, come on. All right, so yeah, so those are your diagnostic tests and treatments. So we can do treatment, we can give you antibiotics, right? Anti-inflammatories, and then we can do pericardiocentesis. You got pericardiocentesis, you got paracentesis, you got thoracentesis, you have centesis. So which one is this one? Pericardiocentesis, right? And then if you're doing multiple one of those, like 3 or more, then we just put a window into their heart. Valentine's Day is coming up. Okay. Which is a pericardial window where they just open a little window, little slit, and it just pours out into the pleural space and gets reabsorbed.
Oh, they don't have tube?
They can put a tube and they can attach a tube to that when they do the pericardiocentesis is an option. But the window is just a specific where they have to go to surgery and open it up. All right. All right. Where do you want to go next? I didn't fill out hypertension or CAD yet. Where do you want? We've got to vote for CHF.
Yeah.
All right. So CHF. So again, you someone uploaded a chart.
Yes.
Good stuff. All right. So you want to be able to separate it out. So like this is just going long ways. When you have a chart, sometimes it can fit on 1 or 2 pages, and it makes it much more geographically or visible to you. All right. So CHF, you have what? All right. You talk about your causes and general stuff. This is just all physiology. So, unfortunately, sometimes you have to recap all your phys, right? So the phys is we're not going to test you on it. We're not going to say which valve opens when, or what is afterload, or what is preload. You have to know how it's going to affect preload and afterload. If this medication is going to do that, what the goal of therapy is for CHF, right? Are we going to do preload or afterload, right? But that concept of preload afterload is just physiology, right? So I recapped it there because it can be, maybe some of you have taken physiology 10 years ago, some of you taken it last year or 6 months ago. So we're going to recap it there. So those are the things that all affect cardiac output, and then our meds are going to affect that, right? Do you want to go into that, or what do you want to talk about?
Reduced ejection fraction.
Mm-hmm.
And you say left versus right, heart failure, classic CHF. What exactly are we trying to say here?
So it used to be called just CHF, right? From the 80s, from the 1800s, like that's my own time, from the 1800s, right? So the 1800s is when you had they called it hydrops, which is edema, and that was CHF, right? They had CHF and that's it, and it was CHF all the way up to like the 90s, and they changed the name to systolic diastolic CHF, and then they've evolved in 2010ish. They have HFrEF and HFpEF, which makes it super easy to learn, right? So, but it used to be HFrEF for since the 1800s. That's reduced ejection fraction, and now they discovered with the echo and more tests, it's like, well, there's actually people that can develop heart failure when they have a preserved ejection fraction, not a poor ejection fraction, but a preserved ejection fraction, right? And they find on echo, they find a muscle that's grown and hypertrophied, and they're not able to fill as well. Therefore, they have a diastolic heart failure. They can't fill good. Yes.
Gotcha. So that would be preserved ejection fraction.
Preserved ejection fraction means you have a preserved ejection fraction, means your EF is not affected, right? Yeah, it'll be obvious. I'm not going to say, it's 43%. Which one is it? All right. It'll be, they have an EF of 20 or they have a 25. They have an EF of 60 or 55. All right. Yes. So systolic heart failures, they cannot empty, right? They're doing one of these. Can't go anymore. All right. It's a systolic failure because they're all dilated, right? Dilated out, and they can't function good. They don't have a good test score, right? Because the EF is your test score, right? If you have a volume 100 cc's and you put out only 30, right? That's a 30%, right? What a good volume is 70% passing.
Is ejection fraction then just counted as left ventricle volume that's ejected, or does it also?
Yeah, when we talk about EF, we're looking at left ventricle. You can look at other ventricles, but yeah, we're looking at, when we talk about just EF, without any kind of specificity, it's just the left ventricle. How good is the left ventricle?
Gotcha. So then reduced ejection fraction would be systolic heart failure.
Yes, it used to be called systolic heart failure because it was unable to systole. All right, and then that's your classic heart failure, all the way back from the 1800s. You have left versus right heart failure, right? And that we're talking about left versus right HFrEF.
So is it safe to say that this would be the equivalent of left-sided heart failure?
No, it's both. It's when your ventricles are unable to put blood forward, it backs up, whether it be left or right.
Gotcha. Gotcha.
All right. Asymptomatic. So HFpEF is just found on echo, just like MVP. That's cool. All right. And so but if you are at risk, right, there's like, it's something happened here. You have, it could be age, it could be an inflammation that caused it, right? You have smoking, you have, obesity, all these things contribute to that ventricle being beefy and unable to feel good, right? Or feel good. So you have a diastolic heart failure, and that puts you at risk for systolic heart failure because that big muscle is not great, right? It causes ventricular hypertrophy, it's ventricular remodeling as well. So it can be started on similar agents as well, right?
So there'd be like a mild MI, but you'd still have preserved ejection fraction.
So for mild MI, usually MIs are going to lead to your HFrEF, but this can put them at risk for MIs. And then, like I said, it's gonna put you down the pathway to HFrEF and just complete failure.
So PEF, or is it progressive or PEF to REF?
Yeah, so PEF can progress to REF, yes. Right, but HFrEF is a classic. Whenever you see when someone says CHF, you're thinking HFrEF because that's the one that has symptoms. That's where we're doing all the things. All right. You can think of preserved EF as pre-CHF, but sometimes you skip steps. You can go preserved EF to death, or preserved EF to cardiogenic shock, or preserved EF to massive MI or whatever it may be. All the complications of it, right? But the one that has the most complications is going to be our classic CHF, which is your HF reduced ejection fraction, HFrEF, and it's classified as less than 45%. All right. Yes.
So when someone has like acute on chronic CHF, that's when they have the chronic CHF and then they have the acute exacerbation of it.
The CHF is always chronic, so that you can't just have, can't get CHF for a day, right? Can't be life in the day of CHF. It's going to be, CHF is yes, it's congestive heart failure, but it's heart failure because of an acute, of whatever event it might have been, right? And now you have this level of function, and you're at risk of being readmitted every single time. So there's that picture on the slides where it shows every event, right? The most common reason for hospitalization is for CHF exacerbation and COPD, which we talked about, right? But CHF exacerbation, each time you have that exacerbation, your function declines, right? Until it leads to death, right? CHF is like a diagnosis of cancer. You can slow it down, right? With chemotherapy and whatnot with cancer, but with CHF, we can slow it down by preventing ventricular remodeling and changing lifestyle and such, and you can maintain for a while, but it has a downward spiral.
So the acute exacerbation is basically like an episode where you cause further damage.
Yeah, so acute exacerbation or acute on chronic CHF is something caused that to happen, right? So that's where that failure acronym is, right? You forgot your medications, you couldn't afford the medications, you couldn't, you had medication intolerance, right? Or you have a dietary indiscretion like on Super Bowl Sunday, right? You have all these things that contribute, or an infection, right? think I spelled it out over here. So failure. So we talk about complications of CHF exacerbation, right? You forgot your meds, right? You have arrhythmias. You all of a sudden go into AFib, right? Because they have the CHF and it keeps, progression keeps going downward, and that atria starts getting bigger and bigger. And now you have structural causes of AFib, right? Which were one of them was CHF. So now they have AFib, and now the AFib has put them in, and now they're even progressing further downward. And that's the reason for their admission. They had just had new onset AFib, or the reason for the admissions they had pneumonia or COVID-19 or influenza A, right? Or they didn't change the lifestyle, or they just reduced their lifestyle choices, but didn't eliminate them. Then they can lead to ischemia and infarction, to an MI, right? Like we tell them, stop smoking, right? But if they smoke 1 to 2 cigarettes, that's not stopping smoking, right? If we tell them to cut out cholesterol and they still eat meat and dairy, that's not cutting out cholesterol, right? That's just reducing it. You still are at risk, right? And then lifestyle, right? They still choose to do meth. Okay, that's gonna progress it. Okay.
So it is in sense, temporary. The exacerbation is temporary, but your end result after the exacerbation
Is always reduced function at that point, right? Like we talk about MS on Monday and multiple sclerosis. It has a progression of debilitation, right? You keep getting debilitated. There's different varieties, but that have a faster progression. But each time you have an exacerbation, it's going to cause decreased function. Same thing with CHF. This is true with most chronic diseases, right? Like with COPD, they have different stages, right? Just like this has different stages, right? It's just stage 1 through 4, right? With COPD, same thing, right? They can barely walk 5 feet and they get short of breath. Same thing with, they have a lot of overlap with CHF. They can walk 5 feet, get CHF, or they have dyspnea right there with the littlest movement, right? And that's what your symptom of CHF exacerbation is, where they have dyspnea at rest, right? Whereas CHF is dyspnea on exertion, right? The exertion could be going to the bedside commode and back, or it could be going to the top of Mount Whitney and back. I don't know. That's too extreme. It's going down the street and back, right? So that's a sign of just CHF, where you get dyspnea on exertion. You're walking, and you get short of breath.
So then, what would be the reason to, after they, I guess, cleared their acute exacerbation, why would they be discharged with NDCs?
So so the contraindication to beta blockers with CHF, right? They are in a state of poor inotropy, right? And we know that beta blockers decrease inotropy. So it's probably not, it's like, here, I'm going to help you out, right? And then that's not going to help at all, right? So you have to you vasodilate to help, reduce afterload. You also decrease preload by giving what? So yeah, ACE and ARBs can do it, but we give diuretics for sure. We're going to give IV diuretics, and we're going to give IV nitrates to really vasodilate, right? So that's really your acute treatment. And we can even increase inotropy acutely, right? We can give DIG as a couple times, but then we'll progress to the big boys, the dobutamine and dopamine, right? Epinephrine even. These are going to increase contractility, get them through this acute stage. And once they are good, then we need to send them home on beta blockers. And yes, it decreases inotropy, but that's like risk versus benefits, right? The cause of the disease of CHF was ventricular remodeling. So we want to stop that piece 100%, which your beta blockers and your ACE and ARBs will do.
Gotcha, because the result of clearing the acute exacerbation phase is more remodeling.
So your exacerbation phase is going to cause more stress on the heart, right? SNS cascade, the RAS, and then if we afterwards, we want to avoid that, right? Because now they're going to have decreased function afterwards, and decreased ability to pump blood forward.
So you had remodeling before, which led you to CHF, and you had an acute exacerbation, more damage, which now instead of creating more remodeling on top of that, you get beta blockers so that you just leave them at where they were before.
We start them back on their home meds, and those home meds are designed to do that. Yes. So the ARNIs, the neprilysin inhibitors, so they prevent the breakdown of the good guys being your AMP and BMP, your atrial natriuretic peptide, and your brain natriuretic peptide, which is mislabeled, but nobody wants to claim ownership over. All right, just like ARBs, they say they're angiotensin 2 receptor blockers, but they're angiotensin 1 receptor blockers because the guy that discovered it first called it angiotensin 1 receptor, but it's actually an angiotensin 2 receptor that it binds to. But cool. And so nobody wants to claim responsibility for it. Either way, your BNP and ANP are natriuretic, right? They put Na in the right? In the urine. So they promote sodium loss where water follows. So they promote diuresis, right? And they also they promote the breakdown of the RAS. So that's great because now we have less angiotensin 2 around. So they inhibit the enzyme neprilysin, right? Neprilysin breaks down AMP and BNP, and neprilysin is going to break down the angiotensin, or is going to not break down the other one. But AMP, BNP are going to be all involved in that process.
So AMP, BNP is essentially what we're doing, or we're
Mhm.
trying to
Yeah.
assist AMP and BNP by giving IV
Mhm.
diuretics.
By giving these, by giving these the sacubitril, your ARNI. There's only one, the sacubitril.
But you're saying that it promotes diuresis.
Yeah, it's going to help with diuresis. Yes.
Basically telling you like something's wrong here.
Yeah, so it gets released in response to atrial stretch. If your atrial stretches for any reason, your BNP goes up, right? And the reason why it would go up is if you have like mitral stenosis, or you have tricuspid stenosis, or you have a fluid volume overload due to kidney failure, right? Or you have a wee for the wee, where they drink so much water and they get fluid overload, right?
Gotcha. Nice.
You heard about that, where when the wee came out, the radio station encouraged it.
Oh, yeah.
Not 2 liters, it's like gallons.
Wee for the wee.
Mm-hmm. Yeah, it caused the girl to die.
Yeah, I think she was trying to win it.
Mhm. Yeah. All right, but that would increase your BNP because you had atrial stretch, right?
Gotcha.
And diluted her sodium so much that her brain couldn't function. All right, what else you got? You still want to? So you got, so what do you, I didn't go over, I didn't spell out all the meds there, but there is a chart, but I can fill it out later. But you have beta blockers, ACE inhibitors, and ARBs. Those are important. But I kind of put the goals there. Your goals of therapy is to reduce ventricular remodeling. That's your primary thing, right? To give them Lasix at home and digoxin at home, not going to do much, right? That's just going to be symptomatic treatment, right? Sometimes, some advanced patients, they can have like a whole arsenal of drugs. Like, oh, I'm not feeling too good. Let me get some of this guy, some of this guy, right? But they have to take their baseline meds. They have to take their beta blockers, their ACE inhibitors and ARBs, right? And MRAs as well. All those guys are inhibiting angiotensin 2 and also beta 1 receptors on the heart. That's what's causing ventricular remodeling.
So then how are MRAs?
So they're what? They are they are blocking the they're blocking the aldosterone function. Okay, aldosterone has a little bit of effect on the heart. So all right, what else? So that's your goals of therapy. So we're going to categorize them, kind of figure out where the commonalities are and what's different, because what's different is usually what gets tested. Yes.
Right side of heart failure can lead to left. Can they both?
So right leading to left and left leading to right. So yes, right heart failure, you're like especially in acute exacerbation. And also with chronicity. So if your heart doesn't work, right, it can't pump blood forward, it's never going to get to the left, right? And you can lead to poor cardiac output, but that's not going to cause left heart failure, right? Whereas if your left heart fails, if the blood blood goes back into your lungs, and then it puts stress on the right heart, and the right heart can fail. But that's more for acute processes. So when your right ventricle just fails, you have a right ventricular myocardial infarction, it can't pump blood forward, and therefore your left ventricle doesn't get the preload at once, and therefore it can't pump blood forward, and you have a low blood pressure and cardiogenic shock. That's more of like an ICU topic. And so,
And it's not oxygenated, basically.
but you wouldn't have chronic RV failure leading to chronic LV failure. But chronic LV failure is the most common cause of right heart failure. And then you also have other things that can lead to right heart failure, such as what? Besides left heart failure? Cor pulmonale, right? Which means what? You got something respiratory, right? What's something respiratory? COPD, right? I mean, maybe long-standing asthma, but COPD is really a big culprit of that. Another thing is obesity, right? Obesity, hypoventilation syndrome is a big thing that causes they're too big to breathe, right? So all the fat on their chest makes it so they can't exhale at night, right? And they get hypercapnic, and it causes pulmonary hypertension, all kinds of bad stuff. But yeah, so cor pulmonale is due to a lung problem, where they grew up with cystic fibrosis, right? What's that?
So like sleep apnea.
Sleep apnea can lead to hypoxia, yeah, and lead to that. Okay, so that's left and right heart failure and the causes and the general stuff, right? Touched a little bit on treatment, right? Pharmacological, and then like surgery, we can replace the heart, right? But those aren't common unless you live in China and are rich, right? Sorry, that's 2 Chinese jokes. I'm sorry. So yeah, we had a weather balloon joke before because when we turned on the projector, there was a camera looking at us. But anyways, I mean that's a real thing that's on the black market. So that's. Anyways, but heart failure is you can fix it with a heart transplant, but it's usually the younger population, and it's going to be and it's extremely rare to get the heart transplants, right? And when you get heart transplants, we're not going to go into that, but you can have there's other unique things that happen with that. All right, but yeah, mechanical support until you get to that point, and then we have CRT, right, which is not what a Republican hates, but it's that's cardiac resynchronization therapy, right? It makes the left and the right ventricle contract simultaneously, right? So the left ventricle is like this, and the right ventricle is doing its thing, right? If you have left failure, the left ventricle is doing its, the right ventricle is doing its thing, and the right ventricle is just like all weird, right? It's all dilated, and it's not able to pump blood out because EF's less than 35, and then they're going to sync it up so they contract at the same time. It looks like a 3rd-degree block, but I mean, it's 3rd-degree block has to do with like the AV node. All right, this is just the ventricles are all misshapen, right? And you want to make them sure they're contracting at the same time. It's doing like right then left, and then that rocking motion can throw off the EF. Okay, you guys assume that missed a beautiful performance. Okay, and then AICD because they have arrhythmias that can occur with this AFib all the way to VFib, VTAC because the ventricle's all dilated out and doesn't work good. Okay. We got 2 meds that affect your eyes for side effects. What are those 2 meds for CHF that affect your eyeballs? Digoxin and ivabradine. So ivabradine and digoxin cause vision changes, right? That's something unique that you can look at when you're looking at the table. It's like, oh, vision right there. Little eye emojis if you can. Right. And then which ones reduce afterload and preload? You can always probably get to both answers eventually, but like what's their primary function? Like nitrate's primary function is to reduce afterload and they reduce preload also because they work on the venous side. So that's like their primary function. ACE inhibitors, ARBs, they're going to really work on afterload. And yeah, preload a little bit with aldosterone blockage. Yes.
With writing, the side effect of the vision change, like is it more of like blurriness or?
I think so. Ivabradine works on the sodium channels, the funny sodium channels of the heart, and also the sodium channels in the eyes. So you have to carry impulses for the eyes. You have to have sodium, potassium moving back and forth, the action potentials, right? So you have difficulty with that nerve impulse. They're gonna be screwed up. Yes. What is a funny sodium channel? I don't know. Yeah, they're at nightclubs. I don't know. Right, but they're found in the heart and the eyes, and then we block them, and we're going to we block a sodium channel with the hot water on the heart. You're going to reduce the threshold to reach intrinsic activity, right? So you're going to make your heart rate slower, right? And that reduces the workload in the heart, right? It's like calmate, it's okay, tranquilo, right? So don't work so hard. All right, what else? All right, you go with CHF? But about the teaching, just we'll keep quick on the teaching. That's a good static question, right? So you have, what do you teach a patient with CHF? When should they call 911? Because they probably are having a CHF exacerbation and you want to fix it, right? Before it gets worse. Right, so you look at just the symptoms, right, of CHF, left and right, right? They get dyspneic, they get, they're not going to assess their JVD. It's like, hey, your JVD is 5 centimeters plus, go and call 911, okay? All right, make sure you get your flashlight, make sure you're at a 45-degree angle, and get someone to get a ruler. And if it's more than 5 centimeters, you go ahead and come on in. All right, no, that's not a good teaching strategy, but that's how you assess JVD. All right, so you call 911 when? So you got weight gain. How much weight gain? So 3 plus 3 to 5, 3 pounds, 5 pounds in a week, right? Or 1 to 2 kilos. You got chest pain. That means you probably be having an MI, or just it's not adequate blood flow outward to support your coronaries. So you got dyspnea, right? Just dyspnea where? Because they're always got dyspnea on exertion. I get tired all the time when I go up the stairs of my apartment. So at rest, so dyspnea at rest is key to calling 911. All right. You told me you hear worsening crackles and auscultation all the way up to your apices. Go ahead and come on in. No, that's not going to be a good teaching tip. All right, but you can tell them about what else. They usually have a cough, right? That cough is like nonstop. That probably means that cough is because of irritation of your phrenic nerve, right? From the pulmonary edema, right? So they should probably come in, right? They can have a frequent cough, but if it's like persistent all the time, that's time to probably come in. Okay, you got weight gain, cough, you got poor cardiac output. It's end game. You gotta come in now, right? And that's your chest pain, shortness of breath, right? So you have to have, that's definitely to come in, right? They're supposed to take their BP anyways. They take their beta blockers, so they're gonna know. I mean, blood pressure is a little bit low, so I'm with a little bit. It's like this top number is 72. So you gotta get. So why don't you come on in, right? So short of breath at rest, because they're always short of breath. That's their thing, right? Those are the Hulk, right? That's my secret.
Shitty, because then their heart wouldn't even be able to compensate because of beta blockers.
So that'd be a reason to hold your beta blockers when your BP is low as well. And it's a good segue to orthostasis, right? Because BP meds are going to cause orthostasis, every BP med ever, right? So it's the same teaching for orthostasis, which is what? Yeah. So careful, right? So careful with standing, right? So do it slow, all right? Drink some water. Right, that's about it. Check your blood pressure before you give it or before you take it. That way, you're not going to drop it precipitously. And what is too much of a drop in blood pressure if you're in the hospital setting? How do you know someone has orthostasis? So they drop their systolic by 20. That's more important than the 10 diastolic, but drop by 20 over 10 points. That's a sign of orthostasis, and we got to think maybe I might have a fluid status issue.
And that's the same thing as assessing for static vitals.
That's orthostatic vital signs, yeah, where you assess them supine, you assess them standing. Okay. So they got poor appetite for a long period of time. That's time to come in for a CHF exacerbation. Okay. So you could do valve CHF. Where do you want to go next? So PAD DVTs, got a consensus? So I didn't finish hypertension or CAD, but yeah, so PAD, right? So PAD is caused by ASCVD. So we talk about ASCVD, it has all the complications, right? So there's a lot of things we have to draw a stick figure and go head to toe, like hypertension complications are going head to toe. ASCVD complications going head to toe, all the complications of ASCVD. And one of those complications, when you get down to the legs, is PAD, right? As PAD is just CAD of the legs, right? Or angina of the legs is what PAD is. And what's that angina called when you're in PAD land? Intermittent claudication, where you're walking, and you get chest pain, or not chest pain, but leg pain, right? If you get chest pain, that's called what? If you're walking, get chest pain. What kind of angina? Stable angina, right? If it's just chest pain at rest, it's unstable angina, right? If it's dyspnea at rest, it's CHF exacerbation. If it's dyspnea on exertion, it's CHF. If it's it's pain on walking, all right? That, and walking multiple times, that is called intermittent claudication. What if you have leg pain at rest? Constant leg pain or critical limb ischemia, right? So CLI or critical limb ischemia is that at rest, right? So that's if you're doing a chart, you just compare them. That's the difference, right? It'd be nice to just call them the same thing, right? It's like, but anyway, they're not, right? So it's not called just leg pain, right? It's called intermittent claudication, and that progresses to critical limb ischemia.
Which is just always leg.
Yeah, always leg pain, right? Or leg pain at rest, right? And that can then progress to ulcerations, right? It can progress to gangrene, right? So you talk about ulcerations. That's a good static question to compare, venous versus arterial ulcers, right? Do you want to go there next, or so what do your venous and arterial ulcers look like?
Venous ulcers are like pressure ulcers. wherever the blood is pooling.
So pressure ulcers are on bony prominences, right? So that'd be not so much venous or arterial ulcers, right? I mean, it can be, there can be some overlap, but we talked about decubitus ulcers. Those are on bony prominences. Venous arterial ulcers are just there, right? Over areas maybe of high use or high friction, or they stepped on something, right? It doesn't heal good because it doesn't have the oxygen delivery, right? Which one doesn't have good oxygen delivery? Arterial ulcer, because you have PAD, you have a narrowing of the arteries, right? And because you have a narrowing of the arteries, what other symptom would you get? You get less flow to the area and less blood makes your color red, makes you give you blush, right? Right. So that's going to cause a lack of flow, and therefore that's called what? Not discoloration. Pallor, right? So they get pale and pallorous, right? So they have poor color, right? So they have a pallor because I don't want to say discoloration because our venous ulcers have the brown discoloration, right? From the blood that's just pooling there, all right? And it just breaks down. And what's inside of blood that breaks down? Yeah, what side of RBCs? Huh? What's inside of RBCs?
Iron.
Well, yeah, they skipped a step, but yeah, hemoglobin. Inside of hemoglobin is iron. Iron is rusty, right? So they get rusty legs, right? Also called hemosiderin. Okay. So compared to our arterial ulcers, those ones are going to be just pale, right?
Those can pop up anywhere. It's not necessarily areas.
Yeah. All right, so that's color. And then what about, and then we talked about what else? So they have poor blood flow. And what else is that going to lead to? What other symptoms? Because you have poor blood flow. Paresthesia, yes. We got to the 6 Ps, and which P is an important one? Well, we got pallor in there, but I'm trying to get you to like the difference between the venous and arterial. What are you going to see? They can both turn to gangrene. So you got a lot of pain, right? So pain because you have inadequate O2 delivery, right? Inadequate O2 delivery leads to pain and lactate production. And you get pain specifically when? With elevation, right? So pain with dependency or pain with elevation, or those are opposites, right? So do they get pain with dependent when it's dependent? No, so that's what some of you want to teach, right? That shows effective teaching. That they say, I'm going to make my legs dependent, right? Right. Instead of they get pain when they elevate it, when they're the lazy boy and they put their legs up, right? That's going to cause pain. And someone that has a arterial ulcer or some of the venous ulcer, that's not going to cause pain. That's going to actually improve venous return.
Only when they're ulcerated.
Or no, just in general. If they have venous insufficiency, put up your legs, a couple pillows, whatever. Okay. And then also you got going through the P's, you got pain, you got pallor. What's the other one? Get some paresthesias, which you wouldn't see with venous. What else? You might have paralysis. It's usually severe, but before that is
Color or temperature rating.
it can be temperature. Good. So that's called what? Polar or poikilothermia. All right. So they are, if you were to feel their extremities, someone has an arterial ulcer is going to be cold or warm. Be cold, whereas a venous ulcer be warm. It has no problem with blood supply. It has all the blood for days, right? Has too much blood, it doesn't know what to do with it, right? So it just breaks it down and causes discoloration. So then what else do you have with what's another P? Paralysis is late. What else? Pulse. That's a big one I was trying to get to. Is a pulse, right? So pulse is going to be good or bad? Baddish, right? It can be all the way to not there, but that's usually like a critical situation. But it can definitely be decreased on that side. And if you were to have like a venous ulcer on one side and arterial ulcer on the other, which it's more advanced, but if you compare 2 patients, one has arterial, one has venous ulcer, the one with the venous ulcer has no problem with a pulse once you can find it through all the edema, right? There's no problem with pulse. Whereas with our arterial ulcers, we're going to definitely have a decreased pulse on that side. Okay. You have decreased blood flow, and blood supplies warmth, it supplies color, and it supplies a pulse, right? All right? So you got dry and it's bony because also blood provides nutrients, right, and oxygen. So things start drying up, the skin doesn't get the blood flow it needs and the nutrients it needs, right? The skin gets shiny. They both have shiny skin, but because, we have edema, it just gets all congested, just like you have mesenteric edema and you get nausea, vomiting with CHF. Same thing here. Your skin gets all edematous and it can't function well. It's like overwatering your plants, right? Who else has a black thumb? I can't keep a plant alive, right? So if you overwater your plants, they don't work good, right? You don't grow your hairs.
So how does that mix into then ABPI?
So arterial, so you're sorry, ankle brachial pulse index, or ABPI. That is, you're going to have normally, what should you have? Your blood pressure in your arms, if you're standing up, should be X. And what should your blood pressure in your legs be? Higher or lower? Higher, because of gravity, right? That's how Newton works, right? So blood going downward is going to have a higher blood pressure. And it's exactly by how many inches it is, right? It used to be measured centimeters of water. So if you're 70 centimeters, your blood pressure in your legs can be like in the 200s compared to your arms, right? That's how it should be. So if you do ankle over brachial, right? That's going to be a good number, okay? But if your brachial, so your brachial probably won't change, but your ankle, if that starts being compromised, what's that going to do? It's going to decrease, right? So it's ankle brachial, right? So if you have 5 over, so ankle brachial, so say it's just make an arbitrary number, let's say 2, right? So we have 2 in our brachial, right? And we have 5 in our, or say 4. 4 in ours, double it in our ankles, right? So it's ankle brachial, right? So it's 4 over 2, right? 4 divided by 2 is 2, right? So if we have a poor ankle pressure, let's just put it to 2, right? It's reduced by half. 2 over 2 is 1. Right? Do you want me to visualize that?
Yeah, so what's the unit of measurement then, where it's just 0.09 and 0.05 or 0.5 and 0.9?
So let's say we have a ankle, right? Brachial index. This is called the ABPI, right? There's an arbitrary number, right? So you should have a higher blood pressure in your ankles normally, right? That's normal. Okay, so let's just give it an arbitrary number. You got, so we put normal here, right? Oops. All right, so you have normal ankle brachial pressure index, right? Let's just say 4, right? You got 4 in your ankles and you got 2 in your brachials because your leg should always be higher. All right, that equals a total of 2. If you do 4 over 2 is 2, right? 4 divided by 2 is 2. All right, 4 over 2 equals 2. And then if you have a abnormal, right? You have PAD. Then we have a decreased or increased ankle or brachial pressure. All right, you have a decreased ankle, so let's just say 2, right? So it decreased. So now I should have a different color. All right, so you have 2 now, all right? Or let's undo that one. Okay, so you have a reduced pressure. So 2 over 2 equals what? I just made up a random number. So I made easy fractions, right? Really, it'd be like this is your systolic blood pressure.
Got it. So you divide it.
So if you have a blood pressure of, let's say, 180 over 120, right? 180 over 120 is not easy to divide in your head, right? But 4 over 2 is.
Gotcha. So this is just the division of both.
So you can see you're reducing your ABPI, right? And less than what is critical?
0.9.
So PAD equals less than 0.9. Okay.
Oh, okay, and then less than 0.5 is critical in ischemia. Gotcha.
Makes sense? So that's ankle brachial pressure index, ABPI. All right, so that's arterial versus venous ulcers. Talk about 6 Ps and how do you assess 6 Ps? It's assessed bilaterally is important, right? You got to assess this versus that. Okay, so you assess the pulse on both sides, the color on both sides, the paralysis on both sides, the poikilothermia on both sides, right? The paresthesia is like, do you feel in your right leg, your left leg, right? It's hard to elicit that. You can't like tickle them. You feel this?
And it could be asymmetrical.
If it's asymmetrical, that means that leg is compromised, right? And usually when they present with PAD, it's one leg. It's not both legs that occurs with. One leg is always worse than the other. the D dimer. So D dimer is clot breakdown, right? So if you have a vessel here, right, and you have, let's say, an atheroma in it, right, and it then ruptures, right, and exposes what underneath? Some collagen, right, and then we have some platelets here, right? You have little platelets, right, and they see this, and they're going to attach and form a clot, right? So you form a clot, and then eventually you're going to break that down, right? So when you break it down, let's put green, I guess, right? So TPA can break it down, but you're gonna, that activates plasminogen and all kinds of other fun stuff, and that's going to inhibit the clot, right? And then what you get is fibrin degradation products or D dimer. That's from clot breakdown.
For venous problems, would be how recently.
It just tells you have a clot
Your body's attempting to.
because your body's gonna break it down naturally. That's a TPA is a drug, but we naturally break down we have plasminogen in our bloodstream. It automatically, when it starts to seeing clots, it activates, turns itself to plasmin, right? And then it breaks down clots, right? And we give tissue plasminogen activator to activate tissue plasminogen to break down clots.
So spike in dimer means that you have an active clot.
Yeah, but the little caveat there is sepsis causes clots, stimulates clot production.
Oh, so you could have a dimer that's elevated with sepsis as well.
Yeah, so it's not useful in the patient that has sepsis.
Yeah.
But if someone just has like no other symptoms, right, they're here for, but also like post-surgery, right, you're going to have clots because you're clotting, right? So it's not too useful after surgery as well, right?
So if someone were like complaining of like CVA related things and then their dimer's elevated.
Yeah, so they have like immobility and they're just sitting there, and then all of a sudden they have shortness of breath. All of a sudden they're breathing 36 a minute, right? And they're wincing in pain because they have a lot of chest pain, right? That's going to be, and it was sudden onset. Then you could do a D dimer and see if that's it, right? Because they don't have a fever, they don't have a white count, and they didn't have surgery recently. That could be that's a good candidate for that. Okay. And to make a platelet, for this little action right here, you have to have, 10A has to make thrombin, and thrombin has to make fibrin, right? And the fibrin mesh, along with an activated platelet, is what makes a clot, right? Should use a different color, but. All right, so that's where our anticoagulants are working. They're working on 10A, and they're working on inhibiting thrombin, direct thrombin inhibitors, such as what? TPAs works over here. There's only one direct thrombin inhibitor. We have indirect ones like warfarin and heparin, but dabigatran, right? So dabigatran is a direct thrombin inhibitor, and we have 10A inhibitors, which are directly work specifically on 10A, right? And then we have heparin and warfarin that work on the other ones, right? Do you want to do the clotting cascade real quick?
Yes.
So let's save this one. All right, so we have 10A, right? And you have different ways to get to 10A. By the way, 10A is going to make prothrombin to thrombin, and thrombin goes from fibrinogen, to fibrin, right? And fibrin is your meshwork, right? And then you have a platelet out there. Let's put a platelet orange, maybe. Oops, I lost it. I lost my thing. There it is. Okay. All right, so you have a platelet out there, which also is has to get activated, right? And then that platelet was going to make a clot, right? So we have antiplatelet agents that we could give, right? So we have antiplatelet agents. Oops, that's the wrong color. You have antiplatelet, which stop this, right? They inhibit the platelet activation. So that's going to stop clot formation. So when they saw that collagen, they're just going to pass it by. They're going to have some restraint, right? They can go by that clot and that collagen and not get activated, right? So that's why we have aspirin on board, right? And also you have the intrinsic pathway over here, which is what gets stimulated by collagen, right? So collagen stimulates the platelets. It also stimulates the coag cascade. Okay, and other meds we have 10A inhibitors, right? With what are called, They have all 10A in the name, right? Rivaroxaban, apixaban, etc., right? And we have thrombin inhibitors. That's our dabigatran, only one of them. And we have other antiplatelet agents out there, right? We have the clopidogrel, and we have our aspirin, and there's other ones too. GP2B3A inhibitors, all kinds of other fun stuff. But the ones I gave you were your aspirin, clopidogrel, and cilostazol, right? So those are your antiplatelet agents. And we got 10A inhibitors, and we got dabigatran. These are all your NOACs or your DOACs, right? Those are your 10As in dabigatran. Yes. Mm-hmm.
Does that mean that they work inside the vessel and the other things on work outside the?
No, that's just the start of the coag cascade. So our heparin works on which part? Heparin works on intrinsic pathways. So let's do another. So you got heparin works over here. So let's do another different color for heparin. So pink. So heparin inhibits this, a little bit over here as well. It inhibits a lot of things, right? But specifically that intrinsic pathway, right? Whereas warfarin, right, works over here. Warfarin works here, over here, a little bit over here, there. It works at a lot of places, right? If you look at that slide, it shows all the places it works, right? That's your warfarin.
That's also
It's extrinsic, right? So it's going to work on so you can measure INR works on this pathway here, right? Whereas PTT works in the other pathway.
gotcha. And that's why PT and INR are the same.
So PT INR, so PT's been retired in the 90s, but we just still call it PT INR. It's now just INR. We never run a PT. So you have INR and PTT, yes. So duplex ultrasound is just a fancy word for so we can charge you more. It's just an ultrasound. We get do you want the regular ultrasound? The duplex. Of course we get the duplex. What are you talking about? I see. Do you live in a two-story? Do you live in a duplex, right? Yeah, just an ultrasound of the carotids you can do of the legs for DVTs and for PAD a little bit too.
Cath lab with fluoroscopy is not the same as CT with contrast.
Yeah, so cath lab is different than a CT angio. Because cath lab requires a physician there, and they put in the catheter in there, and they go in there and they look around, right? And they can actually fix it if they needed to. Whereas CT, you just give an IV contrast to light up the arteries and veins.
Gotcha. So this is cardiac catheterization.
Mm-hmm. Mm-hmm. So troponins, and so high sensitivity troponins are the new one. So since like 2014, 2015, it's now high sensitivity troponins. And it used to be just regular old troponins, just like it used to be regular old BNPs, but now we have the pro BNP, right? So I'm just gonna make you focus on pro BNP and regular troponins.
Okay.
And they're gonna be much, much higher, right? Because they're much, much more specific. Like a regular troponin back in the day was 0.4, right, to 1.2. But now they're more specific. We're just gonna make 1.2, 120, right? Like really you could have a MI if it's more than 52, which is like close to 0.4. So it's off by like 100, it's like 100 to 1,000 times more accurate, right? But it's, yeah, so the high sensitivity troponins, if it's more than 120, you definitely have an MI until proven otherwise. Right? You could have myocarditis. So it's like, well, when did this chest pain start? Oh, it's been for the last 3 weeks. It's like, well, that's probably not a heart attack, right? It's probably myocarditis. Versus sudden onset chest pain is usually, it's probably going to be some ACS. What's that? No, high sensitivity troponin is just high sensitivity troponin. There are type 1 and type 2 MIs. That's different. All right. What else we talk about? So pro BNP has, it goes by 450s. So 450, 900, 1800, depending on your age. If you're more than 75, I think it's 1800 is normal and lower is normal, right? that correct?
Yeah.
Greater than 450 is
It's less than,
900. Mhm.
if you're over 55, it's less than.
And if it's over that, then it's indicative of some kind of damage.
Not damage, but stretch on the left atrium or right atrium. All right, and again, it'll be obvious that you have a high BMP or a high troponin. Okay. All right, what else? So ASCVD. So that's the cause of all of these things. Like 9 times out of 10, it's usually the cause of these things, right? I mean, yes, you can have a knife wound to your valve and cause valve issues, right? But that's not the most common. Not everybody's getting knife wounds. All right. So ASCVD is what you have to work at to get there, right? And not 9 times out of 10, usually it's modifiable. It's something that it's a foodborne illness for the most part, right? But there are other ways, right, to get it with age, right? Diabetes can be foodborne too if it's type 2, but otherwise those are your modified risk factors are important to be able to teach to get their waist size under control, get their A1C under control, their blood pressure under control, right? Those are all teaching strategies you want to aim for.
And these just reduce your risk, even though at that point you probably already done some damage, right?
Yeah, you do further damage. The damage occurs when you actually get CHF, when you actually get NMI, right? You actually get those a CVA. Sometimes you're lucky you don't have any deficits from the CVA, but the CVA could be just a little bit of deficit or death, right? Or a massive CVA where you're in a vegetative state. So there's all kinds of spectrum to it. Yes.
All of the modifiable changes and you had no long lasting damage, you can get rid of the plaque buildup in your body.
Yeah, that's what the HDL is for. HDL is going to reduce plaque formation, reduce plaques, right?
So it will break down whatever's there
Mhm.
already.
They can, yeah.
Gotcha.
Yeah, but if you already have an aortic aneurysm, HDL is not going to do crap, right?
Exactly.
Okay, so yeah, so those are your modifiable things. You want to know your lipid levels, right? What is a good lipid level, right? So someone shows you their lipid panel, is this good or not, right? If you have these things, which of these things are a risk factor for dyslipidemia and for ASCVD, because each one of these things contributes to ASCVD. How does blood pressure contribute to ASCVD? Yeah, it's just shearing forces, right? It's just shearing going at super high speeds, and it's like hitting the brakes, and it's gonna, as it rounds a corner up to the carotids, right? It's going to cause shearing forces and cause carotid artery disease, or it can cause PAD, or it can cause coronary damage.
And then
Okay.
if you have hypertension mixed with piling crystals, that is more shearing and more.
Yeah, so
scratching.
diabetes can do it as well. Diabetes leads to hypertension, so that's those two are going to go down the same path. Okay. And then waist size and BMI is related to obesity. So inflammation, just in general, can lead to ASCVD. Okay, like CKD leads to hyperlipidemia and inflammation. Smoking is just inflammation and hypertension. Right, diet is all. That's the moral of the story. Right, E2H causes vasoconstriction, and it causes inflammation as well. And E2H is a carb, right? So it's going to get broken down and formed into triglycerides for storage.
So when we're talking, sorry, there's some things that go show. When we're talking about complete cholesterol counts, and you have a triglyceride level, is that mixed into the amount of?
No, it's not a differentiation. So triglycerides and cholesterol are two separate things. Yeah, cholesterol, triglycerides, HDLs, LDLs, those are all separate numbers you can look at. They aren't like part of an ecosystem. And they all kind of work together in some capacity, but they aren't, one's not derived from the other.
So if they say total, maybe I'm like total cholesterol level should be below X amount. Does that include HDL, LDL, triglycerides?
I mean, I can look it up. I'm pretty sure it's not.
Okay.
So you have that number in the sand. It used to be 200. Now it's like 175. So your cholesterol is less than 175. That's a sign, or sorry, greater than 175. Puts you at risk for metabolic syndrome and of course ASCVD.
So that 175 is LDL and HDL.
No, that's your cholesterol. I don't think it adds up. I can look at that. It'd be cool if it did.
I don't know. That's why. Yeah, I think Priscilla had been talking about it.
I'll look into it, but Or someone has, do you have Google?
Yeah.
I don't have. I'm gonna go, I gotta go to the library and open up an encyclopedia.
It's composed of the three main lipid proteins or lipoproteins, low density, high density, and very low density. So it's the combination of
All three? Okay. Yeah, we don't usually measure VLDLs, so that's the one that's missing. So it's approximate. If you were to add up LDLs and HDLs, I guess you would get close to what the total cholesterol would be estimated to be at, but we just measure it anyways. So
Gotcha, okay, that's what I was really confused with some, I was like adding the numbers up and I was like, why they don't.
yeah, so because VLDL, and I already know what a normal VLDL is. So yeah. All right. You're missing something. It's like an anion gap. You're missing something you can't measure.
Yeah.
Right.
So we're just mostly concerned on what the number of HDL and LDL.
Mhm.
and
HDL, LDL, and
number does.
yeah, and cholesterol. And triglycerides can independently be increased as well. But that's not part of your cholesterol. So it's a whole different pathway. But we have medications we can do to fix these. And what medications fix ASCVD? So blood pressure meds and diabetes meds, but also, yes, your lipid meds, anti-lipemics, anti-lipidemic, not epidemics, but your anti-lipid meds, right? So your statins are your go-to. That's going to do like the most heavy lifting. And if they can't take statins, you just say, well, I'm going to do a prayer for you. And also we'll start ezetimibe, right? Because it's not going to be effective. Okay. It's like a 10%, 20% versus like 40 to 60%. Okay. So we kind of skipped a step with complications, but medication wise, right? So kind of what look at your different kind of grouping together, like which ones damage muscles, which ones damage liver, which ones could cause diabetes, which ones, what else? Which ones cause anus issues?
So niacin can cause.
Niacin?
Disease.
Mhm. Niacin specifically cause what again?
Increased blood glucose.
Yeah, increased blood glucose. We put diabetes up there too. All right, so yeah, statins are the best, and they're going to be the most common. Everyone gets a statin, right? You come to the hospital because ASCVD is so common, you're going to probably get started on the statin. So that's it's important to know the side effects of your statins, right? And then ezetimibe and bile acids questions make you fun at parties. Okay.
Oh, it just stops. Okay.
All right. Yes. Eculizumab or evolocumab. Cholesterol absorption inhibitors. Ezetimibe. Yeah. Yeah. So ezetimibe is you're like number 2 in line. So we do statins, and number 2 will be our ezetimibe. Then we'll add some other stuff on. Okay, so those are your meds to prevent these complications, right? Dyslipidemia just means that you have elevated numbers, but you don't have a complication yet, right? They're not gonna have any kind of symptoms. There are some rare symptoms that you can say, oh, you got little fat pockets here and there, but otherwise it's not. All right, so then stroke, we'll talk about on Monday. We'll talk about strokes and how to assess strokes. And then carotid, as we mentioned this time, that's kind of a segue into Monday as well. We talk about carotids, right? You got CAD leading to MI. So what are your symptoms of CAD? And then MI symptoms, they're going to be overlap. You have anginal chest pain. And then MI, how to fix MI, that's going to be Med-Surg 3. That's an acute process. Right here, we're talking about the chronic coronary artery disease, right, which is a chronic condition, but it can lead to this acute complication, just like pericarditis can lead to an acute complication, or CHF can lead to acute complications. Right. And then hypertension, we didn't talk about much, but hypertension can lead to all of its target organ damage, but it can also lead to a aortic aneurysm, which is one of the complications of hypertension. All right, CKD will be like in 2 weeks, right? We talk about your that's a complication of ASCVD, hypertension, diabetes. So it's not always linear. It's like somebody just join the freeway to that piece, right? It's a little bit circular and additive. Okay, what else? So hypertension. So hypertension crisis is a complication of hypertension, right? I don't have the hypertension section built out yet, but hypertension crisis is your complication of high blood pressure, right? And that can be just hypertension, or it can lead to actual end organ damage. It has two different pathways, right? So one of our complications of hypertension is our, it can cause target organ damage. And again, draw a stick figure from head to toe, right? It can cause stroke, cause eye damage. How do you assess eye damage? A fundoscopic exam, not a fundus exam, right? We're looking for your eyes right now, right? It feels like my nose. Let's rub that a little more, right? It's good for your eyes. All right, I'm a dude. What are you doing? All right. So, anyways, you have complications of so going eyes. Then what's next? I mean, you could argue carotids, but that's going to be more. That's a chronic situation, right? But like, what are some long-standing complications, or like I come with like blurred vision? That's an eye problem, right? I come in with a headache. It's like, well, you might have a stroke, a bleed. Okay. So what else? Hearing, maybe a little bit. So kidneys, it can lead to kidney damage, cause a creatinine elevation, and heart damage, right? Causing chest pain. What's up? So yeah, so you can have an aneurysm, right? You have an aneurysm that's rupturing and dissecting, getting worse. Okay. And what else was on there? But anyways, that's your different complications, and then your this could be, that's specifically a hypertensive crisis, right? And there's called emergency and urgency, and it's had like 3 different names in the past 5 years. But either way, the one that causes target organ damage is the most serious one that you want to be looking for, right? You want to bring the BP down how fast? Slow, not fast, right? So you bring it down slow over 24 hours. Specifically, it's like 25%. You want to bring it down. So if it's just in general, so you bring it down slow, but with a big asterisk, because there's 3 different other options. And we'll talk more about hypertension with stroke. So if they have a stroke, it's a whole different ballgame, right? Because they're getting TPA, you bring it down to this much really quickly. And if it's not TPA, do this. And if it's ischemic, do that. Hemorrhagic, do this, right? But one of the asterisks you have to know is the aortic aneurysm, right? Those guys you bring it down immediately within minutes, compared to non-stroke, right? Non-aneurysm, you bring it down slowly over 24 hours.
So if an unstable aneurysm is discovered, then quickly
you bring it within minutes, down to like less than 120. Less than 100 is great. 90 to 100 systolic, right? Because you bleed less when you have less blood pressure, right?
That's assuming that you administer TPA, right? Like,
So TPA is different. So TPA is the stroke pathway. So when you come to like high blood pressure, you have different roads you can take. You said, do they have a stroke? Well, we're going on this road, and this road has hemorrhagic, ischemic, and it also has ischemic, not TPA. So there's those 3 roads you go down, but going backwards. So you had just not stroke, then you have just not stroke, not aneurysm. Then you're going to be going. Then you have to figure out which one that is. Yes. So usually like esmolol is a good option. That's a beta blocker, and it's also it's a what's it called, non-selective beta blocker. They'll give PRN. The PRNs can be unpredictable. They got to bring it down immediately, right? And we have other BP meds, continuous like nitroprusside, which you don't use anymore. Nitroglycerin can do it, but the best one is nicardipine, IV as an IV infusion.
and it would be like that night because the rebound hypertension would be
For which one?
nitro.
Nitro can cause a little bit of rebound hypertension. You titrate it down slowly.
Gotcha.
That's more of an ICU topic in message 3, where how you titrate medications. But yeah, rebound hypertension can be caused by not taking your PO meds. Which ones cause rebound hypertension? Clonidine and beta blockers. You don't just stop them abruptly. You have to taper them off, right? And like calf channel blockers we introduced with hypertension, right? That's your go-to med. That and thiazide diuretics. Those 2 are your bread and butter for hypertension. Yeah, you wouldn't do that. Be CHF is a contraindication to your calf channel blockers and for your nicardipine infusion, right? And your nicardipine infusion or your CCBs cause, or your DHB CCBs cause what effect on heart rate? Cause rebound tachycardia, right? Not bradycardia. Like which ones cause bradycardia? Which your meds cause bradycardia? That's how you want to kind of think of these. So you can kind of, you can memorize side effects on a flashcard all day long, but then when you look at the differences on a table, you say, oh, bradycardia. Which ones cause bradycardia? Beta blockers do for sure, 100%. Who else? Calf channel blockers do not, unless they are a non-DHP. Like for arrhythmias, those arrhythmic ones, verapamil diltiazem do, but we're not giving verapamil diltiazem for hypertension. We're giving our dipines, Yeah, but that's the ABCD drugs for arrhythmias. That's the previous test and the final. But this one is going to be your which ones cause bradycardia. I have Vabradine, which is for your CHF. Good. But for hypertension was another hypertensive med that can cause a drop in heart rate. The Digoxin is not going to be for hypertension. That'd be for yes, but that can cause bradycardia for CHF. What else? Nitrates don't drop the heart rate. They would cause reflex tachycardia if you vasodilate too much, just like calcium blockers would vasodilate too much, then that can cause rebound tachycardia. What's the other one? ACE and ARBs have no effect on heart rates unless you dilate too much. It's not minoxidil. Yep, it's alpha agents. Good. All right, your clonidine works centrally. It stops the SNS centrally. And the SNS goes to the heart and also goes to the vasculature, right? You have alpha-2 agonists, and you have alpha inhibitors, but the clonidine is an alpha-2 agonist in the SNS. All right, so those are your hypertension meds and hypertension complications, and symptoms are asymptomatic, but what's the BP? That's bad.
180.
So 180, 110 means you have hypertensive crisis, right? But it's as far as just BP in general, what's a bad BP? So 130 over 8, is it 90 or 80? 130 over 90, right? 130 over 80. So yeah, so if it's greater than that, that's considered hypertension, especially if it's 3 times and 2 of them are high.
But say if you were trying to differentiate crisis on a test.
Yeah, so it'd be obviously high. They have that and they have target organ damage. That's a sign of damage. All right. What else do you want to talk about? All right. So like as far as practice questions, I have a few. I haven't looked at them in a year. I can look at them. It has some renal mixed in there, but we'll skip the renal ones. Do you want to do that?
Yeah.
So I'm not sure what this looks like. Yeah, I'll post them too. I'm not sure how many I've even written. These are usually when people requested questions in the group chat. I've copied them over for the next time. All right. So last time I kind of typed into it. You want me to type into it?
Yeah.
And then some better way to do it. There's no like bedside table. We have awkward posture here. I'm going to bring this guy this way. We're going to go into lazy mode. All right, so nurse understands patient has aortic stenosis, will have increased gradient of their murmur when they do what? So hand grip maneuver means what? Means increase or decrease afterload? Increased afterload. And this decreases, right? Aortic stenosis. It's the only one. Every other murmur is more increased, right? Has an increased sound. Afterload reduction. That's the afterload reduction means you're going to have what? You're going to have less murmur, right? We'll have increased gradient of the murmur. No, right? This is going to cause, or aortic stenosis gets quieter, right? Or decreased grading, right? With decreased afterload. I'm trying to say hand grip maneuver increases afterload. I think I got confused. So increased afterload will increase it, right? Let's come back to A. So I should stand back up, reduce my preload. All right. Anyways, we have preload reduction, right? So every murmur gets louder, right? It gets louder with more preload. So if we reduce preload, it gets quieter, right? With increased preload. Decreased preload will quiet it. Except MVP, right? And then standing up, that does what? This is also decreased preload. Right? All right, let's come back to hand grip maneuver, right? So increased afterload increases murmur, right? All murmurs.
That'll force the blood past the stenosis,
Mhm.
basically.
You seen this right? Hand grip maneuver, increased afterload. Yeah, I'll come back to that. Anyways, your patient presents with dyspnea on exertion, right? Syncope and chest pain. He says the S3 heart sound with a systolic murmur. Appreciate over the right sternal border. Where's the right sternal border? What area is that? That's aortic, so it's not mitral. So we just eliminated two options right there, right? You says an S3 heart sounds, that's a CHF, right? And they have syncope, chest pain, right? Usually the murmur that causes the most chest pain is aortic stenosis. But if you didn't know that, they notify them they have a systolic murmur and it's over the aortic area, right? What is that?
That's stenosis.
It's heard best over mitral area, right? Which is what? Fifth intercostal space and midclavicular, right? And ditto, right? And this is a mitral regurg this is a systolic murmur, right?
But it's not heard there. Question.
It's not heard best here. All right, so then what do we settle on? Aortic regurg is a diastolic murmur, right? And this one is yes. Okay, so your patient comes to the outpatient clinic for infusion of antibiotics via the PICC line. You know the patient's complaining of difficulty swallowing in a hoarse voice. What would you auscultate? So what do they have? They have endocarditis, right? It looks like, right? They had a central line for a while and they've given antibiotics for something else random. And now they have endocarditis. That's a cause of endocarditis. Endocarditis causes valve issues, right? And you would auscultate what when they have difficulty swallowing in a hoarse voice? So I'd probably give you, you note that patient complaining of difficulty swallowing in a hoarse voice, auscultate I kind of put it in the stem. I'll probably give you more clues. All right, but what are you expecting?
You're expecting
So this could be regurg or stenosis. I'd have to, I think I designed the options to eliminate that as an option. Yeah, I think I did. Because it is, let's see here. So again, I haven't looked at this in a year, so I got to make sure it's kosher. I'll just walk it through. So diastolic murmur, midclavicular line, this is mitral, right? Mitral, and it is which kind of mitral murmur? It's diastolic.
That's I think it'd be your,
It's going to be a mitral, what? Like arms, right? It's going to be mitral stenosis, right? If it's a diastolic murmur, that's mitral stenosis, right? Let's see if that's correct. And you got systolic murmur, right sternal border. Right sternal border, this is what? This is aortic area. And if it's systolic, it is aortic stenosis, right? And then diastolic murmur, left sternal border, right? So left sternal border is what? This is pulmonic area, and it is what? It'd be tricuspid stenosis, right? And then we have, or pulmonary stenosis. I don't know, but anyways, it'd be right-sided, right? Which we're not concerned about, right? And then systolic murmur, left sternal border. So left sternal border again is, this is pulmonic area, right? And it is also right-sided likely, right? And we're not doing right-sided murmurs, so we're thinking about one of the two up top, right? So I have to give you more information in the stem. So patient, because I don't know, we'd say they have, we got you signs and symptoms, which is kind of okay, but I don't know.
because isn't this atrial enlargement?
It is atrial enlargement, and yeah, regurg can cause it, but stenosis causes it more. That's not entirely fair. That's like, I try not to do grading. I try to make it black and white. All right, so systolic murmur. I might just say diastolic all the way down. Diastolic murmur, diastolic murmur. That would clear it up, right? And that's make this left sternal border, fourth intercostal space, right? Is that Erb's point? Fourth intercostal. Let's do fifth for tricuspid, right? That'd be right-sided tricuspid stenosis, correct? And then this would be something pulmonic, And this is changed now, right? Because we had diastolic murmur of rice on the board. Well, it's still aortic area, but diastolic is not aortic stenosis. Diastolic area is aortic regurg, right? And aortic regurg would not cause mitral enlargement or left atrial enlargement. So this would be more specific, okay? So that'd be the right answer.
That's not like.
Mhm. Does that make sense? Sorry, I had to edit the question, but
No cost of space, it's just, you just kind of leave it like that. 'cause it's-
yeah, I mean, it could, I mean, midclavicular, there's only one area that's midclavicular line, right? All right, which of the following describes a patient with unstable angina? So I'd have to do like pro BMP if I was trying to get you to guess BMP now. We'll change that. Pro BMP greater than 450, let's say. All right, which of the following describes a patient with unstable angina? Which one? Which one? So waking through the night with chest pain, right? Yeah, this is sudden. But is there something better, right? Right, because it could be like a CHF exacerbation, or it could be a pulmonary edema, or pulmonary and embolus, or something like that, right? Chest pain during the night after sexual activity. This is stable angina, right? So it could be walking, or fornicating, right? Pro BMP greater than 450 that's CHF, right? And yes, you can, an MI can cause heart failure. That's just reading too much into it. EKG finding ST elevation. This is a STEMI, right? Right, which is ACS, right? But it is ACS. I mean, I'd probably say, yeah, probably put acute coronary syndrome. That'd be more specific. I think I morphed the question. It was looking at Sailor is unstable. That I added this. Either way. Okay. Mhm.
Yeah.
Now that works. All right. They have chest pain, diaphoretic, and agitated. Which chest pain description tells you it is cardiac in nature? All right. So substernal hurts when I lean back. This is pericarditis, right? And it's epigastric and hurts after a meal. This is GERD, right? It feels like a pulled muscle and I feel very fatigued. It feels like a tearing sensation. I can't catch my breath. Aneurysmal, right? So this would be which one? Well, I guess that's why I said cardiac in nature, but I'd have to rearrange this. But let's reword this one. All right. So what would be a right answer to make it cardiac chest pain?
Pressure.
That's too obvious. It is.
Oh, radiating it.
All right. This is cardiac chest pain. Angina. Right. And the client with ASCVD is at a 3-month follow-up. What demonstrates correct teaching that they have what? Well, they did the things, right? Even BP down to 140/90. False. They need to have right. Need what? Less than. That's the goal, right? There it is. I need to bring my edge tail down to at least 70. Bring it up, please. Right. So I need to bring up my LDL to at least 100. So they had ASCVD, right? Client with ASCVD. And then you put down 130 if no ASCVD. And then I need to bring my triglycerides down to 175. Triglycerides should be less than 150, right? Less than 150 is target. All right, I need to walk the dog every day for at least 10 minutes. That's 70 minutes of activity. Make it greater than 150 minutes. So we got to make one of the options right. Let's do this one.
130, yes.
Okay,
Over 750.
750, whoa.
true. Okay, there we go. Now we got a correct answer. Okay,
All answers are wrong.
all right. HFREF has what?
Less than 45.
Mhm.
So A is for.
Oh, no, I don't use confused, right? Yeah, it's, 45 is a lot.
So it would not decrease preload. It's just, let's make this, yes, myocarditis can lead to it, but that's probably a little bit left field. I'd probably put something else associated with valvular issues. That'd be more specific. Okay, so this is correct, right? This causes dilation and HFREF. Whereas your HFPEF is due to inflammation, right? Right, decreased preload, not with heart failure, right? And at EF greater than 45%, this is HFPF. Okay, it's important to do the rationales because it could be flipped. HF, the question we asked about HFPEF, right? And then now this A will be correct, and we've changed C to something else. Okay, so that was the correct answer down here. All right, which of the following would be consistent with HFPEF? I don't think I'm going to do this to you, so I'm not going to make you do stroke volumes. All right, real quick, what causes HFREF and HFPEF?
No.
Or not, but it's not males that cause, it's just the.
That's a risk factor.
Mhm. So this is not terribly specific, but diabetes, hypertension, I mean, they all can cause both. I'd have to specify which one I want you to look at.
Yeah,
Which causes
which
it.
modifiable risk factors.
Mhm. It's, yeah. Right, what are modifiable risk factors then? So male is not modifiable, like birth gender, not so yeah, ASCVD can be modifiable. I mean, there are varieties that aren't, but that's not 9 times out of 10, it's going to be. Mhm.
Unless we'll even have genetics.
Yeah, so I'd have to specify something else, maybe let's say, right, smoking, smoking, I guess, right?
Yes.
Yes, but
Right, you can even put vaping in there, right? And then obesity is modifiable for the most part, right? Hypertension is modifiable for the most part. There are non-modifiable versions. We could say, I don't know, and diabetes can, I have to be more specific. We put DM2, right? Okay, so then next one, what causes HF? Oh, I should have just left it that way. That was designed on purpose. But hold on. Oops. That was a purpose of that was to do to show that a critical thinking level question, I think, but it didn't really pan out. What's that? Okay, so like what causes A1C is this. Let's put this one down here. Okay, so yeah, so diabetes A1C at 9.2. So it has to be more specific. This would be the ideal question here. Like what would cause HFREF, HPF? So if you have uncontrolled diabetes, that can lead to ASCVD, which is kind of unrelated. I'd have to like really, this wouldn't be a perfect question. This is just a off the cuff question, but BP 146.92, yeah, that can cause damage, right? BMI 37 can cause ASCVD, which causes damage, right? Creatinine 4.2 is your CKD, LDL 202 is ASCVD, right? And XY chromosome is a male. All right, client with cor pulmonale has what symptoms? What is cor pulmonale? That's right heart failure, right? What does right heart failure have? So dry cough is due to fluid in lungs from left heart failure. All right, cor pulmonale is a cause of right heart failure, right? True? right? Cor pulmonale is core from the pulmonales, right? So heart failure, the coronaries due to lung problems, right? So dry cough is associated with left-sided heart failure, whereas poor appetite is what is due to fluid in mesentery, right? Which is due to right heart failure. Right, so that one's correct, right? Systolic murmur. It'll be both. It's not really specific. I have to say systolic murmur over right sternal border. All right, this is what? Aortic stenosis, which causes left side heart failure, right? So that's wrong. JVD? Yes. Right, pink frothy sputum. All right, this is what? Specifically HFrEF. Okay. Oops. All right, patient with CKD has low EPO. That's the renal section here. These is renal questions. All right, what other questions? You want to make a question together, or it's already 10 o'clock? Are you done? So what kind of question you want to write a question on?
First of all, what time are your office hours over? Because we don't want to keep it up on Saturday.
I don't know. I had stuff to work on this today. So PAD question on what specifically? I have a leaf blower. My wife's like, what's going on? There's someone in the backyard, and she was still asleep. So she heard a fart. So yeah. No, the guy outside didn't know, I guess. Sorry, let's confirm this. All right, so what do you want to do? You have a PAD question?
Yeah. Oh, how about carotid disease? Yeah, we didn't do that.
So carotid disease is going to be, it kind of leans into stroke a lot, but what we know is that ASCVD causes it, right? It can cause a bruit or a thrill. It's usually a bruit, right? If it's really advanced, maybe a thrill, but bruit is what you can auscultate, and it just causes stroke-like symptoms. That's kind of where that's at. And you can procedure-wise, you can do an echo to find it out, or a duplex of their ultrasound of their neck to see it, right? And you can also you can do a carotid endarterectomy. You can go in there and you can rotor out the fat.
Yeah, sure.
The guy couldn't find my address. I should have said my wife heard you fart. So you found it. All right, what else? It's like in 2 years, someone's gonna listen to the recording. Hey, who's that guy that did your leaves? The guy that farted. Yes. You're not dumb. Yeah, I didn't go back to that. I tried to avoid it. I should write it back up. All right, let's make this question right. All right, nurse understands that a patient with aortic stenosis will have increased greater than murmur. That means it gets louder, right? Yeah, so hand grip's going to increase afterload, right? Because aortic stenosis gets quieter with decreased afterload. So that's what that's saying. Increases aortic stenosis.
Are we saying that the
You don't want to do it. I mean, it's gonna make it louder. It's like, cool, look at this. All right, but it's gonna make it worse. The symptoms worse.
Sorry, increasing the afterload will not quiet the ears.
It loudens it. It makes it louder. If you decrease afterload, because every murmur gets louder with increased afterloads, right? Except aortic stenosis. That's the exception to that rule.
Was the slide accurate?
Oh, yeah. I can't take that back, can I? Anyways, so increased afterloads. Let's just do this. Let's do something else. Let's do preload reduction. Let's do leg lift. Okay, increased preload increases aortic stenosis.
Yeah, because hand gripping squatting would create more afterload, which would quiet it. Right?
Yes, the more after, so you reduce afterloads, it does what? Gets louder, right? Okay, that would, this would be then correct also. I guess two correct answers. All right. What else? We say we want a question on PAD? All right, so what kind of question?
Shipping time. Yeah, no, I do.
What, symptoms, treatment, teaching, pulses? What do you want to do?
Oh.
Oh, you mean CAD versus PAD versus
Insufficiency, right? So punch out ulcerations, then we have what?
Just oh, no, it's just
And that's. Oh, if I had the energy, I'd write ankle break.
All right, so which one?
chest pain is from lack of oxygen. So you have punched out is also.
This is due to what? So did it punch ulcerations?
No.
Due to arterial. Okay,
That is piece, well, impact, well, influx would be.
DVT is just a thrombus.
DVT is the progression of venous insufficiency. That's what it progresses to. The decreased flow on duplex ultrasound. That's also PAD, right? What would it show on, DVT? Or DVT venous insufficiency would show what? Or if they had a DVT, venous insufficiency wouldn't show too much, but DVT, if they had a DVT, it would show non-compressible, right? Veins, because there's a clot in there, it doesn't compress.
So that means that it can't close because.
Yeah, because valves, they could close all the way. Not valves, so veins that have valves in them, veins can close all the way.
Oh, so you.
Veins are compressible, arteries are non-compressible usually. I mean, you can compress an artery, but.
Well, and that's like when you see it on the ultrasound, like when you're poking it, like
Yeah.
it reopens back
Mhm.
up because, or with the vein, it'll actually close, right?
Mhm.
Okay.
All right, change in pulse amplitude between both legs.
No.
This is PAD, right? And then pitting edema. Yes.
Blood flow isn't going.
Localized redness and pain.
That would be like.
So that's DVT, right? So if you have to say like arterial pulsations, there'd be or arterial deficiency, insufficiency would be have like whiteness, and it could cause pain as well. I could say also localized redness and pain on dependency, right? So definitely that's definitely going to secure it, right? That makes it not debatable. That's the goal. So I don't know, students argue after the test. So I don't mind arguing. We're not arguing, intelligent debate, right?
No, but it's obvious enough right there.
All right, but that secures it, because you guys will. It's like my grandpa had red legs, but no, it might have been, this is like on dependent, right? That's not going to cause pain.
Well, PAD is arterial insufficiency, basically. So you wouldn't really have redness.
Yeah, and then a good rationale is going to say what, you know, PAD would have, right? Dry, pale, withered away extremities. Okay. Make sense?
Yeah.
Basically, just think of like a diabetic patient with gangrene.
Mm-hmm.
You guys ever seen it in the hospital?
All right, what else? Any last minute questions? Okay. Yeah, for the carotid artery disease, it probably like one question, two questions tops. Right, so I try to, like, when I take the study guide, I go back and I highlight the topics I went over. So I know that I'm not asking like 3 aortic stenosis questions, right? So I'm trying to divvy it out amongst all the topics. Because my frustration in school is like, you know, there's like nothing at all on one topic. And sometimes it happens, right? So because they can only ask 75. Yes. The breakdown. So yeah, I have to put it together. So I have to like write it out. Okay.
I have a question.
Yes.
Will the exam for the select all that apply, will it say that it's a select all that apply
Yeah,
question?
that's the plan.
Okay, cool. Thank you.
Mhm. All right.
Oh, sorry, the crescendo shapes.
Mhm. So who has that?
Yeah, I have no idea.
It's aortic stenosis, right?
It's aortic.
Is that systolic or diastolic? It's systolic murmur, right? So as it's trying to squeeze out, it's not much noise, and as it's at its peak, it's going to have a lot of noise, right? So crescendo, decrescendo.
And that's the only.
So it's
one.
bump, 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 right? So
That's the only one that does that.
Mhm.
Gotcha.
there's holosystolic ones, like, and holodiastolic ones, and ones that have clicks and snaps. And Mhm. On which one? For murmurs, we had like, it'd be like kind of like this, right? So it'd have like 2 or 3 of those criteria I told you. What area you hear it at, where is it systolic or diastolic, and maybe a maneuver in there. Mhm.
Is there gonna be like EKG interpretation of this, like we have the ones that have ST elevation and PR depression? And then
It would say like you have diffuse ST elevation, right? And what does an ST elevation look like? The ST segment, which is after the QRS, is elevated, right? And it'd be diffuse. It's like you see like in a lot of leads. And what is that? Is that myocarditis, endocarditis, or pericarditis? Is it Midas? Midas touch? The pericarditis has that, right?
That specifically cardiac tamponade,
No,
just.
that's pericarditis, which can lead to cardiac tamponade.
So does, systemi doesn't appear in all leads?
No, it's lead specific.
Okay.
So you might touch on that in Med Surg 3, but that's usually more a postgraduate thing where you learn about 12 leads. NCLEX is not going to touch on 12 leads, right? It might say like contiguous leads, like what defines an MI, but it's not going to make you interpret a 12 lead.
Or a metal touch.
Yes. Yeah, myocarditis might have some ST changes, yeah, and there's some endocarditis wouldn't, unless it's causing like CHF issues and causing dilation and P wave changes, but no. Mm-hmm. All right, that help or make you more nervous? All right.
So why not both? I got a question, right?
Mm-hmm.
More confident.
All right, that's it. Thank you guys in Zoom.
I'm not saying I want to go to work today, guys.
Yep, you're welcome.
No, I'm going to study right now.
Thank you.
Welcome.